So we now have this panel discussion on chronic lymphocytic leukemia. I'll be moderating this. So we have the international expert with us for this panel discussion. And our panelists now are Dr. Satish Kumar from Bangalore. He's from Columbia Asia Referral Hospital. Dr. Ashish Dikshit, he's also from Bangalore, from Manipal Hospital. Dr. Chirag Shah, he's from Ahmedabad, from Apollo Hospital. Dr. Shishir Seth, he's from Delhi, from Apollo Hospital. And Dr. Soumya Mukherjee, he's from Calcutta, Apollo Hospital. And Dr. Jai Chandran, he's from Chennai, from Cancer Institute. So that's our faculty for this evening. And we will discuss some questions. First is to Dr. Satish Kumar. What are the diagnostic tests that you would like to perform in a case of suspected relapsed chronic lymphocytic leukemia? Satish.
Thank you, sir. Good evening, everyone. So in a patient with suspected relapsed CLL, we would do the basic test, which is a CBC with differential peripheral cell examination. We should first identify whether the patient has criteria for relapsed CLL and whether he fits into International Working Group CLL response criteria for progressive disease. So along with the CBC with the peripheral smear and differential, I would do a flow cytometry, even if on peripheral blood, to determine the immunophenotype of the circulating lymphocytes, and also identify whether the patient has any evidence of P53 inactivation. We can do a FISH for 17p deletion, because there is a risk of clonal evaluation in relapsed CLL. And we have seen that around 50%, in some studies, around 50% of the relapsed CLL patients can have TP53 mutation. I would also do a TP53 mutation screening by Sanger sequencing or NGS, preferably NGS. So this TP53 mutation analysis has to be done in all cases of relapsed refractory CLL. However, IgHV mutation need not be done because it remains unchanged at relapse. Once we have done once in the early, we need not do it. If it is not done, definitely it should be done. If the patient has any cytopenias, then I would do a bone marrow studies also, bone marrow aspiration biopsy. And also if the patient has any suggestion of transformation, like say patient has significant constitutive symptoms or asymmetric lymph node growth or extranodal presentation or a very high LDH, then I would do an imaging, preferably PET CT scan, and identify the lymph node which needs to be biopsied. Preferably, if the SQV is more than 10, I would prefer that lymph node for biopsy. So this is in short, I would like to do the test in case of relapsed CLL, sir.
Great, Dr. Satish. Can we have some comments from Dr. Sarit?
I fully agree with what Dr. Satish has said, that we would also look again for 17p deletion, TP53 mutation, which can be acquired, but IgHV status would not change. And yes, we're always looking to ensure that there isn't a Richter's transformation based on the clinical symptoms that you've described and the elevation of LDH as well. So we use a PET scan to do that. I don't know if that's accessible to you. Yes? You would also use PET scan. Yeah.
Thank you. Thanks to both of you. We move to the next question. This is a question to Dr. Ashish. Which is the most important parameter that you are looking for while selecting a treatment for a relapsed CLL? Duration of remission, quality of life, PFS, OS, MRD, fixed duration therapy, any other or even combination of these? Ashish?
It's a tough one because basically we are looking at all these parameters when we are selecting an agent for the relapsed refractory CLL. If you ask me a single factor or a single parameter to select out of these, then the duration of remission most of the time will be able to guide us with therapy and will be able to tell us in terms of what particular is the nature of the disease. If the period of remission has not been very long for the previous therapy, then in any case it is looking like more aggressive disease. So it automatically clarifies which agent to use further, and also tells us, like if it's a long duration response after chemoimmunotherapy, then it automatically tells me it is a mutated IgHV rather than unmutated one, even if it has not been done at the baseline. So in terms of that, if a single parameter I need to look at, yes, duration of remission, but the quality of life is something that is the one that is also deciding along with that. Most of these we will prefer as a decision maker in that parameter.
Dr. Sarith, your comments?
Well, thank you for offering me to speak each time. But yeah, it's a little bit different for us, I guess, because we don't, like I said, don't give any chemotherapy in the relapse setting anymore. And so the debates that are going on in Canada now are, well, do you give a BTK inhibitor at the time of relapse after chemotherapy, or do you give venetoclax and rituximab? One is time limited, one has a very generally good safety profile and long progression-free survival. So how do you select between the two? And we still don't have the answer. Some of us say if you have a 17p deletion, TP53 mutation, you should be on a BTK inhibitor because it's not finite therapy. And the patients who were on Ven-R, particularly those with p53 and 17p deletion, had a worse PFS after the treatment was stopped. As you know, Ven-R is a 2-year self-limited treatment. So those are the discussions we have. A little bit different from here.
Thanks, Dr. Ashish and Dr. Sarith. We move to the third question to Dr. Chirag. What are the major challenges you face while considering treatment of a relapsed CLL, especially from the patient's perspective? Chirag?
So yes. So can you hear me?
Yes.
Hello?
Yes,
yeah.
We can hear.
So from patient perspective, the one big factor in India is cost, of course. But other than that, we have a lot of patients coming from out of town. So travel is a concern, and the number of visits, number of laboratory tests required. Then patients with comorbidities, they have different preferences. And what they have had before is what their experience was with the chemotherapy in the past. So many of them are now with choices available. They don't like to have a chemotherapy again. So those are the main patient issues.
Thanks, Chirag. Dr. Sarith, your remarks?
I don't have much else to say. We also consider, as we say, comorbidities. What are the other medications the patients are taking? What are the risks of bleeding when selecting the BTK inhibitors?
Thank you. The next one is to Dr. Shishir. What is your preferred patient profile for selecting the following? Chemoimmunotherapy, BTK inhibitor, BCL2 inhibitor. So patient profile for each one of these. Shishir.
So in relapse refractory setting, the chemoimmunotherapy now means having a limited role, but still means in our country where the finances are limited, chemoimmunotherapy could be an option, especially if patient they have a very good earlier response of these chemoimmunotherapy. So we can again try the agent for these patients, especially means if patient they had received earlier FCR, we can again try with means BR like regime if finances are limited. If finances they are not a concern, then definitely newer small molecule targeted therapy they are means better option, especially if means there is a 17p deletion, then there is no doubt of using these agents because these are the drug of choice. So BTK inhibitor means with the availability of generic ibrutinib, they are relatively more affordable option than BCL2 inhibitor. So the advantage of a newer study of a BCL2 inhibitor that definite therapy means after 12 months of therapy we can means stop the BCL2 inhibitor. So that is a major advantage when we are discussing with the patient, because most of the patient, they are not willing for indefinite therapy.
Okay, thank you, Dr. Shishir. Dr. Sarit, your remarks?
I don't have anything to add. Thank you.
Okay. Dr. Samya, next question to you. If you have been given an option of choosing either a BTK inhibitor or a BCL2 inhibitor for treating relapsed CLL, what will be your choice and what is the rationale behind your choice?
Yeah, thank you, sir. So there are a lot of things which depends to choose the proper therapy for the patients. The most important, the first drug in the initial period, what drug he or she received before the relapse, that is very important. If the patient is on ibrutinib or any BTK inhibitor prior to the relapse, then definitely my choice would go for the venetoclax. But if the patient received VEN, then definitely BTK inhibitors will be the choice in the relapse refractory setting. And again, comorbidity, finance, both are important, very important to choose the drugs. So definitely, if you want to choose, the second option, VEN will be my first preferable option if the patient received ibrutinib in the first, after the first diagnosis.
Thank you. Dr. Sarit?
No, I don't have anything more to add. I think a lot of this has been asked by other people here, but definitely the choice is based on the patient preference, patient lifestyle, what they've previously received, and their comorbidities, and I guess affordability is a consideration as well.
Thank you. The next question is to Dr. Jayachandran. Is bone marrow transplant an option for treating a relapsed CLL? If yes, what is your preferred patient profile for selecting a patient for transplant?
Am I audible, sir? I'm Jayachandran. Am I audible?
Yes.
Yeah. So if you look at the CLL patients, usually they are more elderly patients and the HSCT index is always mostly higher side. So when there are few indications only nowadays to be selecting a patient for relapse refractory CLL, one would be in a younger patient where the 17p deletion, where they are exhausted both the options of ibrutinib and venetoclax, and still the patient is young and is having a matched sibling donor or a matched unrelated donor where the comorbidities are less, we would consider for such a patient for allogenic stem cell transplantation. And in case of a chemosensitive Richter's transformation, in that case, we could consider such patient for allogenic stem cell transplantation. So we had offered for one patient. She was a doctor who is 37-year-old anesthetist who had a 17p deletion. Even she exhausted ibrutinib, venetoclax was not available. The only patient we had done for allogenic stem cell transplantation. I feel these are two indications in a younger patient with 17p deletion or more complex karyotype with less HSCT index and a patient with Richter's transformation be the indications for allogenic stem cell transplantation in CLL.
Thank you. Dr. Sarit, your remarks? Yeah, I totally agree. It's a very rare patient, very rare patient in whom we do transplant, but those would be good reasons too.
What is the response in Richter's syndrome about the transplant? That was one of the condition, what was indication mentioned. So what's the sort of response and outcome?
Actually, we have not done offered any transplant for any Richter's transformation as of now, but as per literature, the responses are not that great. Even the responses are less than 30% with aggressive therapies, and after them being chemosensitive, taking them for allogenic stem cell transplantation would be a great deal. I don't maybe Dr. Sai to that a great answer for this.
No, we have the same success rates, very, very low, not successful, very difficult. Yeah.
Dr. Sarit, they go for CAR-T?
Yeah, we don't have CAR-T available for patients in Canada for CLL at all, not even on clinical trials. Like I said earlier, we're looking at new therapies for for Richter's transformation, we have some trials of bispecific antibodies and other novel things, but nothing established. Yeah, difficult.
So that finishes one round of the question, and now we go to the last round of questions. So we've got 6 more questions. So Dr. Satish, back to you. In a young, fit, relapsed CLL, what is your preferred treatment option and why?
So in a young, fit, relapsed and refractory CLL, it depends upon whether he falls into high-risk category or not. High-risk category, when I say as defined by the recent EBMT European research in CLL group. So if he does not have any adverse genetics, and we have started him on a pathway inhibitor, whether it's BTK inhibitor or BCR inhibitor, and if he's responding well to the treatment, I would continue the same thing. I would not change anything. I'll just continue the pathway inhibitor. But if he falls into the high-risk category, which basically are defined into 2, one is if he has a TP53 abnormality, he has failed chemoimmunotherapy, and is responding now to a pathway inhibitor. If he has a good match, like a well-matched donor without any comorbidities, I would prefer to take him for allogeneic transplant. And if he has comorbids, or if he is has a bad performance status, or not a matched donor and is responding to the pathway inhibitor, I would continue that. If not, I would take him for transplant. The high-risk category 2, where he has failed one pathway inhibitor, whether if he has failed ibrutinib or venetoclax, because of very high risk of progression or transformation, I would take him for allogeneic transplant. Because the risk of transformation is very high, Richter's transformation is very high if they have failed one pathway inhibitor.
Again, Dr. Sarit, your remarks?
No, I agree. There's not much more to say. A young patient with relapsed refractory CLL, has a potential for a long life ahead of them, and so you do want to select the best therapy to give the longest progression-free and overall survival. And it is a challenge. I mean, our drugs are so effective, but they have their limitations. Transplant has to be considered. Not popular.
I have one question for you that was raised in between. If a person has toxicity to ibrutinib, cardiac or bleeding, will you ever switch that person to acalabrutinib or go on to venetoclax?
Yeah, that's a very good question. It's a good question. So the 208 study gives some information with regard to that there is not overlap between toxicities between ibrutinib and acalabrutinib. I mean, there is some, but you can have a lower rate of these toxicities if you switch from ibrutinib to acalabrutinib. And then it is it's a shame to lose the BTK drug based on adverse event only, because the only other option left is the venetoclax, either alone or in combination. So if possible, it depends on the clinical context itself, but if possible, it's best to switch to another BTK inhibitor. In our case, it's acalabrutinib, rather than switching class of drug. Yeah.
Thank you. So, Ashish, according to you, which of the following is the ideal sequencing strategy for treating a relapsed CLL? So I need not read out all this. This has been mentioned and it was sent to you.
Right. So I think chemoimmunotherapy is going to be the last option as a palliative care, if at all I have to use it, provided the person can afford the other 2 pathway inhibitors. So in terms of that, again, it will come down to if the patient is younger, then if it is still a good risk, I'll prefer to use a therapy which is going to offer a treatment-free interval. So there I may choose a venetoclax-based therapy for a longer interval, or maybe 2 years of therapy and followed by withdrawal as an option. BTK inhibitor will be at the same time an option if they don't mind taking it for a long time, and with a reasonable toxicity, which will be also almost equivalent in terms of as long as it is sensitive. Quite a lot of this sequencing also will depend on which particular regimen was used before they became resistant. So if it has already been resistant to BTK inhibitor, then of course the sequence will change to the other type where the BTK inhibitor will not figure at all. So I think the combinations will exactly depends on what was used earlier, what it is resistant to, and it will come down to the fitness of the patient, the wishes of the patient in terms of being on the medications all the time, and what are the comorbidities at the end of the day, whether if there are cardiorespiratory, cardiovascular toxicities already existing, then in that case, possibly BTK inhibitor will be tough to administer. But if there's a renal toxicity, then BTK inhibitor will automatically become the first choice.
Thank you, Ashish. Dr. Sarith?
Yeah, no, I agree. You have to consider the comorbidities and patient preference. The only thing that, the additional thing I'd like to say is if there is a 17p or TP53 mutation, most of us or a lot of us are uncomfortable with the venetoclax time-limited option, and so it would either be a venetoclax long-term if you can get it, which we can't, or a BTK inhibitor in those patients.
I have one question for you. Is MRD licensed to be used in clinics in Canada?
No, we don't have access to MRD, not yet at least. And for the time being, there are no therapies that are tailored based on MRD status. It's mostly for prognosis, so we haven't felt the need to use it in the clinical setting. In the research setting, it's very useful because it kind of gives you a really good sense of the depth of quality of response to a therapy. And for time-limited therapies, I think for BTK inhibitors, the MRD is not there, but the PFS is clearly can clearly be shown for all of them. So MRD might not be a pertinent measure or isn't for BTK inhibitors alone, but in the combination with BCL2 inhibitors or in the context of time-limited therapy, it's going to become more and more useful, or treatment tailoring.
Thank you. Another question I have for you is, do you always stop venetoclax after 2 years in relapsed and 1 year in an upfront setting, or if there is inadequate response, you continue?
The drug is only, the venetoclax in frontline and second line are only licensed for time-limited therapy. So 2 years in relapse and 1 year. We cannot give it beyond that for reasons of cost. Right.
Okay, thank you.
But the data, for Murano show that those people who relapse do it or lose their MRD do it fairly early after or during therapy even. So that, anyway, no, not available.
Right, got it. Question to Dr. Chirag. How do you compare the use of ACAL in relapsed CLL, as in the ASCENT study, against IBRU in RESONATE study and venetoclax in Murano study? Please tell us the key highlights of ACAL over IBRU and veneto in treatment of relapsed CLL.
Thank you. When I reviewed these three studies to try and compare, of course, this is all cross study comparison, but it was quite interesting that between the Acala and ibrutinib, some of the differences are related to the side effects as highlighted, the lower incidence of hypertension, somewhat bleeding, and a little bit of difference in atrial fibrillation. At least in these studies, the AFib difference was not very big between RESONATE and ASCENT. Then the discontinuation rate has been considered bigger for ibrutinib due to side effects. Now comparing the Murano study, the venetoclax plus rituximab, the main advantage has been the fixed duration therapy. Other than that, when I first read about the trial, I was concerned that the TLS would be a very big thing. But in the Murano study, the TLS rate is 3%. So that's not very big. And it means that it seems that if you follow the exact guidelines given how to prevent TLS, the low risk, medium risk, and high risk patient, then I think it seems like a doable thing, at least on this clinical trial data. I don't know if all in all, it's, now we have to wait for the direct comparison of Ecala versus ibrutinib. But as of now, we can say that we basically have three good choices rather than one clearly superior over other. Ecala is, as per the data so far, seems more tolerable, and the best studies that I found was where the ibrutinib intolerance, Ecala was used and tolerated well by most of the patients. So I think that was a better comparison for me of ibrutinib versus Ecala.
Dr. Sarit?
No, I agree with the assessment by Dr. Shiraga. The data that we have so far seem to suggest that in some cases acalabrutinib is more tolerable. And yes, we use Mirano, the Ven-R, somewhat often, and do not see any TLS. It's a little bit cumbersome, with the dose escalation. There's a lot of blood tests, a lot of back and forth with the patient, but it is safe. Seems to be safe, yeah. So I agree. And I look forward to the acalabrutinib comparative trial. I think it will give us the best sense of how the drugs differ or are similar.
Dr. Sarit, any idea whether the coming ASH has this data presentation, ACAL versus IBRU?
Oh, I should have checked that out. I don't think so. I don't think it's coming at ASH, but I'd have to defer to AZ to know.
All right. Okay. So, happy to inform you all there are about 210 participants who are listening to us. Now to Dr. Shishir Seth. In your views in real world, will ACAL differ or will be preferred over other novel agents for the treatment of CLL? Shishir?
Data looks promising that acalabrutinib, that is a selective inhibitor, so the toxicity is limited, so better tolerable. So maybe it will be one of the preferred agent, especially when we are selecting this class, means ibrutinib versus acalabrutinib. And but how much difference it is with the other agent like venetoclax, very difficult to say, because the study that is with venetoclax, that definite therapy that is after 12 months it can be stopped. So I think we need more data to mature to say whether means acalabrutinib that is also can be used as a definite therapy, who are means achieving MRD. After MRD, we can stop the drug and see.
Thank you, Shishir. Dr. Sarit?
Sorry about that. I think we'll have to see what happens. In Canada, acalabrutinib is fairly newly accessible, and so with a little bit more time, we'll see if it's going to be used more. I don't know. Some of the U.S. experts seem to favor the acalabrutinib for its safety profile, but time will tell.
So now the second last question is to Dr. Soumya. In the treatment of CLL, do you think that BTK inhibitors can be used as finite fixed duration therapy, BTK inhibitor based treatment for a fixed?
Yeah, I think till date the data which we are getting that any BTK inhibitors should be continued for longer durations. No finite therapies there. Few studies definitely on acalabrutinib is there that they're going to stop the drug after a few years. But the issue is that MRD, I think, will be the most important determinant in those trials. But for now on, I think it is not advisable to stop the drug after a finite duration till the data matures.
Thank you. Dr. Sarit?
Yeah, I agree. There are some data coming out of Resonate 2. So in the frontline setting, patients who needed to stop BTK inhibitor for intolerance, not for loss of response. And they were able to maintain their responses off of the therapy, particularly if they were in CR versus PR. But that's not a common occurrence. And I would say that BTK inhibitors must be given indefinitely, until relapse or intolerance. But it may be fixed when given in combination with BTK with a BCL2 inhibitor, and I agree, MRD will help to define that.
Thanks. We come to the last question to Dr. Jayachandran. What is your opinion on fixed duration therapy while using BTK inhibitor-based combinations? And lots of combinations have been put over here. I don't know how much of that data is already available to us, but anyway, your comments.
So all the combinations, all the permutations and combinations of this combination of ibrutinib or BTK with BCL2 and also an CD20 antibody, these all combinations have been tried in phase 2 clinical trials, and most of them had endpoints of MRD-based endpoints, response-based endpoints. And if you look at, I think MRD has not come into the clinic set, and how far achievement of MRD would translate into survival benefit is a great question. So again, there are pros and cons of using the combinations. In India, again, the cost is an issue, and I would love to sequence rather than give all at a single time. Even though they are at finite treatments, most of them are 15 cycles or within 2 years, something. Most of the trials have shown, all are based on MRD endpoints. I would love to sequence them one by one rather than using it at one go. Maybe for a younger patient who is affordable, maybe we can give it for a finite treatment. And it is better to see whether we can use the BTK inhibitors as a finite treatment, as per the previous question. Maybe we should think about sequencing rather than using it at a single go.
Okay, one last time, Dr. Sari's remarks.
Yeah, no, I totally agree. I think combination BTK and BCL2 is not going to be very popular in Canada. The costs are just astronomical. So I don't really know what the future holds in terms of that. It's nice to be able to stop treatment, but we'll have to see. Seems costly. Yeah.
Right. So that was our last question, and
I have one question.
Please go ahead.
The cost of the drug of the novel agent, that is a big issue, and big affordability means we are using venetoclax in AML very frequently nowadays, and we have seen if we are giving along with voriconazole or posaconazole, the dose requirement of venetoclax that come down to 100 or 150 milligram per day. So means maybe for cutting down the cost of these drugs, we can use such agent. So the drug requirement will be much lesser.
Right, thank you. Yes, that has been done in AML quite frequently across the world. Okay, so I don't think there are questions in the question box. Kalpesh, there are any questions lying? I don't see.
There are 2 questions, sir.
There are 2 questions. Will you like to put them up?
They are already there, sir.
They are already covered? All right, thank you then. So, on my behalf, I thank everybody, Dr. Sarit and all the Indian faculty for sparing your 2 hours and educating all of us and those 200 audience, of which almost 100 are our fellows and trainees, and I'm sure that they have benefited from the experience of all of you, and grateful to Dr. Sarit for her expert remarks. I've been informed by AstraZeneca, Dr. Drupad, that ACAL versus IBRU data will be presented in ASCO 2021. So fair enough, in 6 months we will have that.